Ling Yi was told to tell them to not take until prescribed. All right, does everybody have a purple and pink pill? A purple and white pill? Yes? Raise your hand if you have a purple and white pill. Raise both hands if you have a purple and white pill. Wave your hands around if you have a purple and white pill. So you guys don't have a purple and white pill? You don't have it? Who doesn't have it? Right here, we don't have some? All right, raise your hands up in the air and wave them if you don't have a purple and white pill. Wave them like you're super excited to get a purple and white pill. Oh God, you're not very excited. Not yet. Who else needs them? Stand up if you do not have a purple and white pill in front of you. I think everybody has it? Okay, very good. Can I just get started, Movie? Okay, all right. Good morning, everybody. Good morning. It is a real honor for me to be here with you today and for the next couple days. I'm Patrick Ryan. As Mui introduced yesterday, I am a professor at Columbia University in New York City in the US, and I'm also the Senior Director of Epidemiology at Janssen Research and Development, which is part of Johnson & Johnson. And I'm also a proud collaborator of OHDSI, and I'm eager to share with you the work that we are doing. I have to admit that while yesterday Mui said that her Mandarin wasn't very good, I can tell you that my Mandarin is much worse. So I will be doing these lectures in English, so I need to make a deal with you. If you don't understand anything that I'm saying, in the morning or this afternoon or for the next 3 days, I need you to please raise your hand and say stop. Okay? We have translators to help, and it's really important that you understand everything that we're going through. And I'm going to do the typical dumb American thing, which is when you don't understand my English, I'm just going to say my English louder and slower and think that you'll understand it better, which doesn't actually work. So if you don't understand anything I'm saying, please raise your hand. If I'm speaking too fast, please raise your hand and tell me that I'm speaking too fast. Am I speaking too fast now? All right, stand up if you're understanding me. Raise your hands if you're understanding me very clearly. Sorry, I don't understand. Okay. All right. You may sit down. So I have to admit yesterday was quite interesting for me because I got to watch Mui and Ling Yi present to you, and I didn't understand anything they said all day long. And what was interesting was almost every slide that they presented was a slide that I actually created in the first place. So I was interested in watching all of you as you were listening to the lectures to try to get a sense of how much you were understanding of the material. So I'm just curious, how many of you feel very comfortable in the idea of a standardized vocabulary. The material that Mui was presenting this morning. Stand up if you feel very comfortable with the idea of a standardized vocabulary now. A few. Okay, very good. That's helpful. Thank you for sitting back down. Stand up if you are interested in the idea of a vocabulary. So maybe you didn't understand it completely, but did it seem like an interesting idea? Stand up if you found that interesting. Okay. So most of you found it interesting. Not all of you understood it. Is that a fair summary? Okay, that's good to know. That's very helpful. Ling Yi went through the common data model, which was a way to structure electronic health record data in a common way so that we can run different types of analyses on it. And he walked through the different tables that are in the common data model, and he tried to give you a sense of how we take data that's captured in these hospitals and we can put it into a format that everybody can use for analysis. So I want you to stand up if you understand the OMOP common data model now. You feel like you understand that now. Stand up. Okay. Was that almost? You almost understood it? All right, you understand it. Very good. Okay. So people are still learning about this. Well, I want you to stand up if you're interested in the idea of having a common data model, the idea that we would want to standardize our data to run analysis. Stand up if that's interesting to you. Okay. Okay. And there's a few of you who are not standing up. For those of you who are not standing up, I want you to wave your hands if you understand my question, but you're just not interested. No, okay, just not it. That's okay. Don't have to be interested. That's fine. All right, thank you very much. You guys can sit down. So what I see is that most of you are interested in the idea of a standardized vocabulary, a way which we could speak the same language when describing diseases and medical treatments, and that you're also interested in the idea that we could standardize observational data so that we could learn from it. But at the same time, yesterday was probably pretty challenging for many of you because it's a lot of content that Mui and Ling Yi presented to you, and so not everybody feels like they completely understand it. Do I have that? Nod your head if I have that about right. Yeah? Okay. That's okay. I can tell you that I am the inventor of the OMOP Common Data Model, and it took me many years to understand it as the person who created it. So it is not fair that we would expect that you would understand it in one day. And that vocabulary that you were learning, we are still working on it as a very large team of researchers. We are working on it every single day, and we have been for 10 years. And it is still not done, and we still don't understand why it's not right. So it is not fair to expect that you would understand it in a day either. It's okay that you don't understand it. What's important, and why I'm glad to see that many of you stood up, is not that you feel like you have complete understanding of the entire idea, but it's more important that you understand the value of the idea. The idea is that we would like to be able to speak a common language when doing research so that we don't have to have the awkwardness of me speaking English to you and you translating it in your head into Mandarin, but rather that we can work together in understanding our ideas. And it's also very valuable to have the idea that you could do research not just here at Fudan University in the hospital across the street, but that if you have a clinical question that you think is important, that could improve the lives of patients, that you could ask that question not just here at Fudan, not just here in Shanghai, not just here in China, but you could ask your question everywhere around the world and get an answer that could improve the lives of billions of patients everywhere. That's the idea that we're actually trying to work on together this week. Okay? So how many of you, stand up if you're interested in improving the lives of patients? You are not interested in improving the lives of patients. Okay, that's fine. That's fine. That's okay. Not everybody has to be. Okay, so the rest of you are interested in improving the lives of patients. Okay? And how many of you, so I want you to now raise your hands if you believe that you already are doing everything you can to improve the lives of patients. Everybody feel like they're already doing everything that's possible to be done already. Some people. So many of you feel like there's still more to be done. Okay, great, good. I'm glad that some of you are open-minded. All right. Now, yesterday what I observed was that when Mui was presenting about the vocabulary, I went into the back of the room and I watched. And I noticed that many of you had your laptops open, and some of you were following along with the exercises in the tool Atlas. And some of you were surfing the internet, or shopping, or whatever you were doing. That's okay. But then I noticed towards the afternoon, when we started talking about the idea of creating a cohort that could be applied to a database to find patients who had a disease, that it seemed like many of you got excited. So stand up if at the end of the day you got excited about what you're going to learn for the next 3 days. All right, so like half of you got excited. And the other half aren't excited yet, but that's okay. I've got a cure for that. Okay, you guys can sit down. So half of you are excited. Most of you don't understand the vocabulary yet. Most of you don't understand this common data model. But half of you are excited because you saw something yesterday that was interesting. Now I'm just curious, you can raise your hand. How many of you would like to publish research in a leading medical journal? How many would like to do that? Raise your hand really high so I can see it, so everybody can see it. If you want to publish in a leading medical journal. Okay, so most of you have some interest in doing that. That's good. Now, everybody's hands down. Now, raise your hand if you already have published in a leading medical journal. Nobody. Okay. All right. So most of you want to publish research in a leading medical journal, and most of you have not. Why is that? Are you all lazy? I don't think you're lazy. How many think it's because it's hard? Raise your hand. Is it because it's hard? Okay, most think it's hard. Okay. How many think it's because you just haven't gotten around to it? You haven't had time to do it. Okay. So many of you think you might have had the time, but it's hard. Let's think about what makes it hard. Usually, to publish something in a leading medical journal, you usually require some basic pieces. You have to have a good question. There has to be an idea of something that you think you want to learn about a disease or a medical intervention. So how many of you feel like you might be able to have, or how many of you have a good idea? Raise your hand if you have a good idea. Okay. So most of you don't feel like you have a good idea yet. Okay. Raise your hand if you want to have a good idea. Okay. So maybe if we could work on it today, we could work on the process of how to think of good research ideas. How many would like that? Say yeah if you would like that. Okay. For those of you who think that I'm not going to continue to make you participate in class, I want you to know that I will be making you participate in class pretty much all the time for the next 3 days. So if you're already annoyed by me, get used to it. All right, so many of you would like to learn how to come up with good ideas. That's great. Actually, this morning's session is going to focus on helping you think about how to come up with good ideas. And we're going to try to help you, show you examples of ideas, and help you classify different types of analyses that can be performed against data that could give answers to those good ideas. Okay? So that's what we're going to do this morning. Now, coming up with questions, that's the first step. And it sounds like there's an opportunity to improve in that area, so that's very good to know. Once you have a good question, we need to be able to translate that question into an analysis. That is, define the question in some sort of a way that it could be asked of a data set. Now, how many of you have ever designed an analysis where you've taken a question, maybe from somebody else, and you've translated it into a way to answer the question? Raise your hand. We've got one, couple, cheaters. Okay. How many of you are interested in learning about how to take a question and turning it into analysis? Raise your hand. Okay, so most of you don't have that experience, but you're interested in that. Okay, that's good to know. This afternoon, actually, Kristin and I are going to work with you on how to take your clinical questions and help you start building an analysis using the Atlas tool. Once you design a study, though, you have to be able to run the analysis against data. How many of you currently have access to observational data? Raise your hand. We've got one person who has access to observational data. Okay. How many of you would like to get access to observational data? Only about half of you. Or you're just starting your hands or going lower. When I ask for you to raise your hand, I want you to raise it as high as you can, like you're trying to touch the ceiling. So how many of you would like access to observational data? Okay, many of you. Okay. Good. One of the things that we hope that you will take from this entire week class is that if we can make it easy for you to think about research questions, and we can make it easy for you to think about how to design studies, and if we can make it easy for you to publish papers in leading medical journals, then making those things easy should make you speak to your faculty and your research advisors and your health systems, and to encourage them to try to make access to the data available for you. And the most easy way to make that data available is by doing the effort to convert it to the OMOP common data model that Lingyi presented. Because that common data model becomes a standard way that organizations all around the world have determined that we can make it easy to go from a research idea to a paper in a medical journal in a very efficient period of time. Now, I'm just curious, since most of you have not published in a medical journal, what would you think is a reasonable time that it should take to go from a good research question to a paper that you're going to submit to a medical journal? How many people think that it is that process should take 5 years or more? Raise your hand. It should take 5 years or more? Keep your hands up, please. Okay? How many people think that that process should take 4 years or more? Your hand should still be up. All right? How many people think that that process should take 3 years or more? All right. Most hands are going up. How many people think that the process of going from a research idea to a paper in a journal should take 2 years or more? Keep your hands up as high as you can. As high as you can. That is not as high as you can. Raise your hand up high. Very good. How many people think that it should take, to go from a research idea to a published paper, it should take at least a year? 1 year or more. Raise your hand. Okay. If you're not raising your hand right now, stand up.
It's a trick question.
Okay. How long do you think it should take to go from a research idea to a published paper? You think it should be less than 1 year? What would you think is a reasonable amount of time? 3 months? Okay. And how about yourself? How long do you think is a reasonable time to take to go from an idea to a paper? What's that? 10 years or more. Okay. All right. Very good. Excellent. Okay. So right now, by surveying the group, we have one very ambitious student who thinks that it's possible to do a study in 3 months. Most of you think it should probably take a year or 2 to do a study, and some of you think it takes a decade. What if I were to tell you that by the end of this week, I'm going to take a question that you come up with, and I'm going to produce a paper? Raise your hand if you think I'm crazy. As high as you can reach. I won't take it offense. You think I'm crazy? Kristin thinks I'm crazy. Okay. Why do you think I'm crazy? I'm pointing at you.
I think it's a short time.
You think it's a show time. So short term. It's a short time. Oh, it's too short of a time to do it. Okay, so it's just not possible for us to do the work.
Possible, but I don't know how to do it.
You don't know how to do it. Okay. Okay, so it's just too short. Okay. What about the time do you feel is too short? Is it coming up with the idea?
I think it is possible to come up with idea, but I don't think it's possible to finish the paper.
Okay. So the coming up with an idea, that might be possible in the next week. Okay? Okay, that's very good. Designing an analysis. Do we think that that's possible to do in a week? No, that might be hard. Okay. And writing the paper, we don't think that that's possible to do in a week. During the week.
You mean we can come up with an idea and write the paper in a week?
This week. Okay. You think it's possible for me? What if I say, is it possible for you?
I don't know.
You don't know. Okay. Stand up if you would be interested in coming up with an idea and publishing a paper by the end of this week. All right. There's a couple people who are like, that sounds boring. Okay. Okay. So I'm going to level with you. I am crazy. And I'm also going to take a research question and write a paper before we leave this class on Thursday or Wednesday. Whenever I'm getting back on a plane, I'm going to get back on a plane with a paper that we are going to write together. Right? That's what we're going to do. Okay? So I want you to wave your hands if you're super excited now. Okay. Very good. Now, you may sit down. Now, what I noticed yesterday when about half of you got excited by Mui's presentation, and what I noticed now is that I think that you guys might have a disease. That disease is OHDSI. OHDSI is an abnormal condition that involves irrational belief that science can be done in a new and different way. You all seem to have it now since all of you stood up, but you're in luck because I've created 2 medical interventions. One could help you if you are excited about having OHDSI. It is the purple pill that you have in front of you. The purple pill is going to help you pay attention very, very closely for the next 3 days so that you can focus and make sure that you learn as much as possible over the next 3 days so that you too will be able to write papers. That's the benefit of taking the purple pill. But the purple pill has some side effects. It includes the fact that you may experience uncontrollable laughter over the next 3 days. It may also have some other side effects that we haven't yet learned because I just made this medicine on my flight over here 2 days ago. So you have an option, which is you could take the purple pill to treat your OHDSI and possibly be able to concentrate more, but maybe have to do a lot of laughter and be embarrassed. You have another option, though, which is to take the white pill. I made this white pill to be a little bit less potent, so I'm not sure that it will help you concentrate as much as possible. Therefore, the side effects of this drug might involve boredom and frustration by listening to my annoying voice for the next 3 days. But I've given you each 2 medical options. You've been diagnosed with a condition, OHDSI, and me, your prescribing physician, is giving you the option of 2 medical interventions. You can either take the purple pill or you can take the white pill. So what I want you to do in front of you is I don't want you to take it yet, but I want you to choose which of these 2 pills you're going to take right now. And pick it up and hold it up, whichever one that you're going to take. Okay? Purple pill, high dose, increased focus, some side effects. White pill, low dose, less effective, less side effects. Hold it up for whichever one you've chosen. What's that? The white pill? So you're holding up? Okay. Now what I want you to do is if you are holding up a purple pill, I want you to stand up and go to that side of the room. And if you are holding a white pill, I want you to stand up and go to this side of the room. So get up. If you're a purple person, go to this side of the room. If you are a white person, go to this other side of the room. Everybody should be on one side of the room or the other. Stand up and go to the side of the room. Everybody should be standing on one side of the room or the other. Very good. Okay, so you all have chosen the purple pill. You're looking for, you think that this might help you have increased focus, but you might be prepared for the side effect of uncontrollable laughter.
Yes.
You all have chosen the low dose pill. Less effective, but possibly less bad side effects of being embarrassed. I want you to look at who chose what, and I want you to think about whether this group of people who chose the purple pill, whether you all are similar or different from that group of people who chose the white pill. Why did you choose the purple pill?
I think it's magic because if we believe it, something happen.
So you think it's magic?
Yeah.
Okay.
I think it might happen.
Okay, you think it might happen?
Yeah.
Because I'm crazy enough as it is. I'm making you eat candy and telling you that it's a drug. So,
But I truly believe that.
okay, so you believe it's magic, okay? Why did you choose the purple pill?
Because I believe in myself.
You believe in yourself. Okay. Why did you choose the purple pill?
I want to be more focused.
Because you like the benefit of being more focused. Why did you choose the purple pill?
I think laughing is not a bad thing.
Laughing's a good thing, so it's not a bad side effect. Okay. Why did you choose the purple pill?
I think it's interest for me.
It's in your best interest?
Yes.
Okay. Why did you choose the purple pill?
I don't care about the side effects.
You don't care. You're okay to laugh. Okay. Why did you choose the purple pill?
Maybe I think it's good to me to pay more attention to the lecture.
So instead of sleeping through yesterday's class, you're going to stay awake today. Okay, so paying attention is a good idea. Okay. Anybody else have any other different reasons why you're choosing the purple pill? Did anybody choose it because they like the color purple? That's why my daughter would have chosen it. Everything that's pink and purple, she chooses. Anybody choose it because they think it's going to taste good? No? Okay, so those are your ideas, okay? Why did you choose the white pill?
I don't know how to choose.
You don't know about the truth of whether these things actually work. Okay? So figure take the low dose, that's the safer thing. Why did you choose?
Safety consideration because it said that it will be more safe.
So there's less side effects.
Yes.
And you're worried about the side effects. Understandable. Why did you choose the white pill?
Because I want to be diseased.
What's that?
Be diseased.
You want to be diseased.
I believe in myself.
Oh, you believe in yourself. Okay, very good. Why did you choose the white pill?
Because the purple pill cannot, couldn't help or be helpful to me.
You are already so focused and so concentrated that this drug will not have an effect. Okay. Why did you choose the white pill?
I don't like the side effects.
Don't like the side effects. You don't want to laugh because a boring life is the way to go. Okay. All right. Any other reasons why you guys selected the white pill that there's different?
Is anyone else afraid of being embarrassed? I am very afraid of being embarrassed.
I think take more time to compare those and give more data so I can make a better choice. Before that, I want to be safer place to choose the white, but we still participate.
Ah, very good. So you're not convinced about the effectiveness of this purple pill, and you'd like to see more research done to prove that it works before you're willing to take it.
Yeah, so at this part, I still want to take a white because I want to be involved and to see. But before you make a choice, I actually don't want to choose both because both doesn't give me strong evidence for me to choose any one of them. But you only give us a choice, must choose not to participate.
Yep.
Choose the white part.
Got it. Very good. So if I had given you the choice of no treatment, you might have chosen that and let these poor suckers experience the effects of this drug. Okay. Any other reasons? Anybody choose it just because it's white? Anybody choose it because it looks like it's going to be tasty? Okay. So before you go back to your seats, what I want you to now do is I want you to eat your pill, swallow your pill. I've now prescribed it to you. So take the one that you want to do. Don't go back to your seats yet. Stay there, stay there. But I want you to everybody commit. Oh, if you don't have your pill, then take it. I want you to commit and go ahead and eat your pill.
是你们选那个，你选的那个就是那个。OK，这边选了红色的，就是红色的，这是我的白色的，是你的白色的。对。
All right. Now, That was an American licorice. How many thinks that that tasted disgusting? Interesting. Okay. I thought it tasted like your Chinese wine that I got to try last night. Okay, so now looking at these two groups, I want to go back to this comment that was very, very important. We would like to study the effects of these medical treatments. We want to know that the purple pill is more effective than the white pill at focusing concentration. We can already see that it helps you stand better, obviously. It clearly helps you pay attention more than this white pill. If we want to study the effects of two different medical interventions, a purple pill and a white pill, then we need to be able to do research that actually begins to understand which of those two different medical interventions have different effects. What we've just done was design an observational study. What we just did was we gave patients, you, a choice of different medical interventions. You made a choice for a particular reason, whether it be because you believe in yourself, you don't worry about laughing, you like the effects, or you just like the color purple, but you had a choice and a reason that you chose the purple pill. And you all made a choice to choose the white pill. And now, over the next 3 days, we're going to be able to watch you all and determine whether or not this group remains more focused than this group, whether this group laughs a little bit more than this group, and we're going to be able to determine whether or not that is the effect of having taken the purple pill versus not taking the white pill. So that's the study that we're about to conduct, is to figure out the effect of the purple pill versus the white pill. Now, to do that study, though, this is an observational study, and so there's some concern about our study design. Does anybody see any reasons why that might be a problem? Go ahead.
I think those choose the purple pill may be some people who is less able on focusing on the class.
Wow, he just called you out. So everybody here, he thinks that the people who chose the purple pill are less able to focus than the people who chose the white pill. So therefore, if we observe a difference, we don't know, is it because of the effect of the pill, or is it because of something about the characteristics of the people who chose the pill? So this is an idea of confounding, the idea that there's some other effect that might be going on that we don't know. Now, you've brought up an interesting one, which is people have different levels of focus. But can you observe any differences between those of you who chose the purple pill and those of you who chose the white pill? Do you see anything different between your cohort of people who chose the purple pill versus this cohort of people who chose the white pill? Yeah.
I think there might be something that's affect like our seats, because we choose our purple pills and it's a little bit difficult for them to come here. So there might be some people in that kind of cohort, they want to choose the purple one, but they're lazy to come here.
They're lazy. The white people are lazier than the purple. That makes sense. So there is something about geography of your seat that might influence choice, because people who are geographically closer to the purple world may choose purple treatments, and people who are geographically closer to the white world might choose white treatment. Any other differences? Yes? Very good. So I'm going to repeat it just so everybody could hear it, because it's a very, very good and important point. Because you chose the purple pill based on my description of what I told you it might do, you may be more likely to feel like you're hyper-focused. You may feel more likely to want to laugh because I told you that this pill is going to create laughter. And because this group, I told you that you probably wouldn't get the same level of focus, and I told you you might not laugh as much, you might be less inclined to focus, as evidenced by the fact that you're all just sitting down, or to laugh. And in an experiment, a randomized experiment, if we were to conduct a research study, we might choose to, for example, tell people or randomize the treatment assignment. So don't tell someone whether they're getting the purple pill or the white pill, and not tell them what the effects of the pill would be, but instead to tell them that you are getting one of two treatments for which we do not know the effects of either of those treatments. And that way, the researcher, the patient, would be blinded to the effect that is going to happen. So therefore, they wouldn't be biased to behave in one way or the other. The reason why it's very valuable to do placebo-controlled randomized experiments is exactly because if the doctor who's doing the experiment or the patient who is getting the treatment knows what to expect, then their behavior might change. It's a very important point. And here, because we don't have the luxury of doing a randomized experiment, but instead we are doing observational research, we have to figure out how to deal with the fact that you guys might be biased towards certain behaviors differently than the white group. Any other thoughts? Anything else that makes this group, the purple group, your cohort, makes you different? Yes?
I think people choose purple pill tend to have the willingness to pay attention to the class. So if the result shows that we focus more on the class, it couldn't prove that it is because of the pill. It is because of the people who choose the pill.
So you may all just want to focus more anyway, and therefore it has nothing to do with the medicine. Got it. Very good. Did everybody hear that? Did everybody hear? Okay. Very good. Is there any demographic differences between those of you on the left side and those of you on the right side? Do you see differences in age, gender, size, race? You don't see much difference? So when you're looking for those differences, when you are physically looking at each other, what are you doing in your head? How are you, when you say you don't see much difference, let's say it's okay. Okay, well, let's start with some of the, this is very, very good. So let's start with some of the basic things. So what you did was you looked at this cohort of patients and you estimated the breakdown by gender. So you, in your head, calculated the proportion of people in this group that are female, and then you calculated in your head on this side the proportion of people who are female. And you decided that those two proportions were kind of similar. Now, if this was real research, we probably would want to do something better than just in our heads. We might want to actually compute the number and write it down. Right? I don't know much about people who are interested in focusing and are willing to laugh. But it looks to me that we actually have a larger proportion of women on this side. I don't think it's a 50-50 breakdown. It looks like it's probably 60-40, something like that. Whereas over here, I'm thinking it looks more like a 50-50. So I think there might be a gender difference between these two groups. But I'm also eyeballing it and doing some math in my head. We could compute that as a number. Now, I don't know how much you all care about people who take the purple pill versus people who take the white pill. But let's think about some of the clinical diseases that you all spoke about yesterday in class. Which one of you is interested in cervical cancer? Oh, very good. Okay. So what's the gender breakdown of cervical cancer? They're female. Okay. That's probably a good example there. So we would expect to see all the people who get cervical cancer be women, because women happen to have cervixes. But if I were to ask you what is the breakdown of age, what is the age when someone gets cervical cancer?
I assume it's a little bit elder than us, like maybe 40s to the 60s.
In their 40s to 60s, okay? So you could imagine, so just so everybody could hear it, so the comment was that the age distribution of women with cervical cancer, that they're probably diagnosed in their 40s to 60s. But you're assuming that. How would you know that? How would you learn that information?
I just assumed in my brain and my database because I can't remember the figure very clearly, so I just think about that.
Where did that figure originally come from, probably? Have you read, you've read a textbooks?
Yes.
Where do you think the textbook got that number from?
Maybe there's papers, but I think the figures will change as time goes by.
So the figures might change as time goes by, or it might change based on what country you're in, or what treatments are available. So what might be interesting would be to create a cohort of people, where the cohort of people isn't people who took purple pills, but it was a cohort of people who had cervical cancer. Because if we had that cohort of people, we could ask questions like, what is the age at the time that they were diagnosed? Okay. Other areas, who expressed their interest in studying atrial fibrillation? Somebody yesterday said they were interested in, yes, atrial fibrillation? So atrial fibrillation, if I asked you what is the gender breakdown of people with atrial fibrillation? You think it's mostly men? Okay. What percentage are men?
Actually, I don't know.
Don't know. Okay. That's okay.
I'm just interested.
You're just interested. So we'd like to learn. So if we could create a cohort of people who have atrial fibrillation, you could learn the answer to the question, what percentage of people with atrial fibrillation are men? And that could be valuable because, as you said, there's probably an answer in a textbook somewhere, but that answer might be old, or it may not apply to the population you're interested in. You know, most of you, or I guess almost all of you, are here in Shanghai, certainly here in China, and many of you are reading knowledge that's learned about medicine that was not learned in China at all. How many of you feel comfortable that the treatments that are given to, that you will be giving as doctors to your patients are based on their effects having been studied on white guys like me? How many of you feel good about that? Nobody feels good about, you feel good about that. Yeah? Why do you feel good about that?
You know, I think like, because I know the modern medicine is derived from Western.
Mm-hmm.
So I think like the Western doctor may present, more advanced, procedure or methodology or maybe ideas to treat patients.
Okay. So possibly just understanding that there is a group of people who got the purple pill. So if I told you, for example, that the people who got the purple pill, I had previously studied a bunch of Americans before I came over here, and that's why I know that you guys are going to be more focused and laugh more. Possibly that's better than not having any knowledge, but the question is it going to have that same effect when we apply it to students here in Shanghai? Okay? So that's an open question that we would need to think about that hopefully this experiment will help. Now, all of you are the purple pills. You all are hoping to have increased effects of focus and possibly side effects. Do you think all of you are going to be hyper-focused today? Raise your hand if you think all of you are going to be hyper-focused. None of you think you're all going to be hyper-focused. How many of you think individually you yourselves are going to be hyper-focused? Okay. All right. And how many of you think that all of you are going to be laughing uncontrollably today? 2 people think we might all laugh hyper. And how many of you individually think that you are going to laugh uncontrollably today? All right. I mean, that's already a start. It's a giggle. Okay. So another way that we could use a cohort of individuals is not to determine whether the purple pill is more effective than the white pill, but it's to say, amongst the people who took the purple pill, which patients are going to laugh uncontrollably? Or amongst the people who are in this cohort, which are going to experience the effect of being hyper-focused? You guys can all sit down and go back to your seats. The reason we just spent a lot of time talking about this, and we're going to reinforce this point tomorrow, is because everything that Kristin and I are going to teach you today is as simple as thinking about the choice of choosing the purple pill or the white pill, and the decision of what kind of research do you want to do once you've defined cohorts of populations that you're interested in. There's lots of different questions we can ask. And so this morning we're going to focus on how to help you all think about coming up with good questions. But all of them start with a simple idea, which is create a cohort of people who have some characteristic, and then let's study them. And we can study them in different ways. We can characterize the people who are in that population to understand what is the percentage of people with atrial fibrillation who are male, or what is the age distribution amongst people who have cervical cancer. We can study the effects of medical interventions by comparing the purple pill to the white pill. And in that case, we are trying to understand the comparative effectiveness and the comparative safety of treatments. But we have to be concerned about the issues that were brought up of blinding and bias and the fact that the populations are different. And we can also use these cohorts to actually study, to actually create prediction models that are going to tell us amongst people who belong to one cohort, the purple pill, which of those people are going to go on to have an outcome, uncontrollable laughter. Okay? So this idea of coming up with a good research question is as simple as define the cohort of people that you want to study and decide what kind of question you want to ask of your cohort. Wave your hands if this is making sense. And ring a bell if it's making sense. Okay. All right. So I'm going to guess. Okay, so now I'll ask another question. So now I want you to raise your hand if you think that what I'm saying is overly simplistic. That what I'm saying must be too easy or too good to be true because what I'm saying seems very obvious and silly? Raise your hand if it seems too simple. All right, nobody thinks that's too simple. Okay. Or you're just not willing to raise your hand. That's okay. All right. What I've actually found over the course of my 2 decades of doing this is that the reason doing medical journal papers is so hard is because people start with very complicated questions and they don't simplify it down to the very basic points. And yet all of you, I assume, raise your hand if you've read a medical paper. Can you raise your hand? Most of you have read a medical paper. My guess is those papers that you have read, the ones that made the most sense to you were the ones that were very simple. Right? They made a simple observation about what happened to patients, and that simple observation was very clear, and therefore you could remember that information. So what we're going to do is we're going to focus on coming up with simple questions that we can answer with simple analyses. And it'll turn out that those simple questions will actually be very valuable questions because most clinical questions that you guys are going to be thinking about do not have answers anywhere in the medical literature. We have not answered the vast majority of questions that need answering. And so there's a lot of opportunity to do research to try to get to good questions. So with that, let's start our presentation. An hour and a half in. I mentioned this. I'm just disclosing that I'm an employee of Janssen Research and Development. I don't think anything we're going to talk about is relevant to anything of my company, but in case anybody is concerned, let me know. So, what we're going to be doing for the next 3 days is going on a journey. We're going to be going on a journey from data to evidence. And data is the information that's captured in the hospital every time a doctor is interacting with a patient. That is data. Evidence is answers to clinical questions. The challenge is how do we go from the data that's being captured across the street here to the answers that we're going to publish in medical journals. That's what we're trying to solve. Now, it's important to highlight that when we think about different types of data, that there are many different types of data that are available around the world. And so we cannot talk about data as one thing. Instead, we have to appreciate that different databases have different characteristics. For example, some databases may capture information about the pediatric population. And who said that their interest is pediatrics? Somebody said that yesterday. Somebody said they were interested in pediatrics. You said you're interested in pediatrics. Okay, very good. So in the OHDSI community, we have many children's hospitals who have data, but it's only about children. That is a tremendous data resource if your question is about children. It's not very helpful if the question is cervical cancer. We have other data sets that are only the elderly population. That might be a tremendous data set to study atrial fibrillation, but probably not pregnancy outcomes. We have population differences in terms of socioeconomic disparity. So populations where people have a lot of money and have private insurance versus places where poor individuals who require some safety net care are provided. There's a difference in data in terms of the care setting. So there is a difference between the data that's captured in the hospital for people who are admitted and stay overnight for multiple nights versus the data that's captured at a general practitioner. Does that make sense over here? I know that you guys mostly go to hospital for outpatient care. What's that? Does that make sense? Okay. There's also a big difference between primary care, so who is your main physician that you see for most of your care, versus specialty care. And that data can be different based on the level of depth and sophistication. But if you go to your cardiologist, you might learn a lot about what is going on with your cardiovascular disease, but you probably won't learn anything from your cardiologist about your cervical cancer. Yeah. So it's important to know where the data is coming from. It's also important to understand the data capture process. We're talking about hospital data, so the electronic health record system that's inside of your hospitals that we can extract data from. But there are other different types of data systems that are out there as well. An important one that is in the OHDSI community is to use insurance data, which is captured for the purposes of reimbursement between the clinicians, the doctors who want to get paid for providing their services, and the payer, which would be either the insurance company or the government program that reimburses care. And that data can be used for research purposes. It's also important to note that the health system itself has a huge effect on research. So in the United States, where I come from, we have a challenge that some people can afford to buy insurance, and therefore they get a certain level of care, and other people cannot afford insurance, and so they have to go to different doctors and get different care. We notice that countries make decisions about what treatments are offered to their people in their country and what's not. For example, medications are approved by regulators, and there are drugs that are approved in the United States that are not approved here in China, and there are many treatments that are used in China that are not used anywhere else in the world. And those effects of country policies can have profound effects on how we answer our research question. So we need to be thinking about these details of data when we think about questions. And importantly, we need to be thinking about how do we know that the answer to the question that we have in our mind is not just a result of one of these differences in the data, but it is actually a true phenomenon that's happening in the world. For example, if I want to know what is the age of people with cervical cancer, well, we might have to think about how is cervical cancer diagnosed here in Shanghai. Are there different diagnostic procedures that clinicians use here in Shanghai than back home in the United States? That might result in a different distribution of ages, even though we might think that the disease is the same. And we'd have to ask, is it because there is a difference in the genetics of a Chinese population versus a Caucasian population? Or is it a difference in the healthcare delivery system? That's something that can only happen if we have different types of data from all around the world available for us to ask those types of questions. So the reason why it's important to understand what Ling Yi was presenting yesterday is because the OMOP Common Data Model makes it possible for us to have different types of data from all around the world into one format so that we can ask the question, what is the age distribution of cervical cancer? And we can ask everyone around the world the exact same question, and we can get back results, and we can actually understand what does that look like, and is it different because of any of these reasons? Does that make sense? Okay. Now, the exercise we just did with the purple pill and the pink pill, I tried to highlight for you that there's different types of evidence that we could generate. And broadly speaking, I'll classify them in three groups. There's clinical characterization. This is descriptive statistics that we could generate about a population. So we might be interested in disease natural history. How old are people with cervical cancer? Or what is the gender breakdown of patients with atrial fibrillation? That's disease natural history types of analyses. that we can come up with a question of disease natural history and write a paper, because most diseases we do not have very well described around the world, unfortunately. We can also do descriptive statistics to understand treatment utilization. So amongst patients who have atrial fibrillation, what drugs do those patients take? I listened to Mui yesterday saying that, I guess here in Mandarin you pronounce it as warfarin, and in the United States I'd say warfarin, so I put a hard R on that. But in fact, there are 5 different drugs that are approved for atrial fibrillation as anticoagulant treatments. There are, at least in the United States and Europe, there's 5 different drugs. I don't know how many of them are approved here in China. But the question is, if there are 5 different treatments for the same disease, which treatment do patients actually take? Do they all start on warfarin? Or do they start on one of the other drugs? Or do they take nothing? Or do they take some other alternative that's not one of the 5 drugs? And the truth of the matter is, we don't know what percentage of patients who have a particular disease take which treatments. So that's an interesting question, that if you have a research question in your mind of a disease and you're interested in, I wonder what treatments patients take for that disease, chances are that is not yet published in a medical journal in a way that is robust and complete. It's a good research question that you could ask. The second category that I'll highlight here is population level effect estimation. Here is questions about the safety and comparative effectiveness of medical interventions. So this is the difference between taking the purple pill and the white pill, and the highlighted comment of, we don't know whether the purple pill works. Well, we can do research questions to compare people who chose the purple pill versus people who chose the white pill, and we can try to see whether or not we see a difference in their level of focus and their uncontrollable laughter. Right? The design that you would think about in those types of questions is for a particular disease that you might be interested in. Think about what alternative treatments patients have a choice between, and then think about asking, what outcomes would you be interested in learning whether or not those alternative treatments are in fact different? And it'll turn out that if you come up with a disease you're interested in, and you come up with 2 treatments that are available, and you come up with an outcome, and you go into the medical literature and search for it, there's a very good probability that the answer isn't in the literature either. Because most questions you come up with haven't yet been studied around the world. The third category, and this is actually where we are going to publish our paper this week, is on patient-level prediction. And there's 2 ways to think about prediction that I'll introduce you to. One is to think about disease interception. So could we predict which patients are going to go on to develop a disease? So for example, could we take all women who are over the age of 30, and could we try to figure out which of those women are going to go on to have cervical cancer, and which of those women are not going to go on to have cervical cancer? That's an example of a prediction problem where we may be able to use the medical history of an individual before a moment in time to predict what's going to happen to them in the future. Now, the example of disease interception is, can we predict someone before they get a disease? Because maybe if we could figure out who's going to get a disease before it happens, maybe we could do something about it. For example, if we think about, someone mentioned, who mentioned that they're interested in hepatocellular carcinoma? Okay. You both are interested. Excellent. So particularly here in China, there's a lot of interest in hepatitis B because patients who have chronic hepatitis B have an increased risk of developing hepatocellular carcinoma. Now, we know that there are medical treatments that can reduce the activation of hepatitis B. Antiretroviral therapies are available. And if patients could reduce the viral load of the hepatitis B, then they could decrease their chance of having hepatocellular carcinoma, of getting liver cancer. But we don't necessarily, or we can't necessarily, afford to give every single person who has chronic hepatitis B an antiretroviral therapy. Maybe because the patients don't know, or we can't afford it, or the health system doesn't have the treatment available, or whatever it might be. But if we could actually predict which of those people which of those people who have hepatitis B are likely to go on to get hepatocellular carcinoma, well, if we knew who was at high risk, we could do something about it. We could treat them and maybe prevent them from getting the cancer in the first place. Raise your hand if you'd like to do that. All right, either half of you like the idea of helping patients with cancer, and the other half of you are bad people, or you're not paying attention. Either way is fine. Okay, so this also bleeds into the idea of precision medicine. Actually, we had a delightful dinner last night, and I was talking a lot about this with Professor Liao, about precision medicine seems to, in many people's minds, mean something to do with that you have to have genetic information about a patient. And that by using someone's genetic information, you could hopefully understand what's going to happen to them in the future. But I want to encourage you to think that precision medicine simply means not settling for what do you expect will happen to everybody, but instead trying to predict what's going to happen to me. And we can use the information in the electronic health record system to do that prediction. So you don't need genetic data to do precision medicine, and it doesn't need to be something super fancy. As long as you can think about a research question, which is, amongst people who have a particular disease, which patients are going to go on to experience some outcome? And if you can think of that question, then you are probably able to do an analysis and do precision medicine. Okay. Any questions? Okay. In the interest of time, I'm going to skip this. Yeah. So Mui presented yesterday about OHDSI, so I'm not going to spend a lot of time repeating things, but I want to highlight some key points to make it clear about why Kristin and I are talking to you for the next 3 days about these topics. Our mission in OHDSI is to try to improve health by empowering a community to collaboratively generate evidence to promote better health decisions and better care. Why is this important? Because yesterday you spent an entire day learning about a vocabulary and learning about a common data model. And at least somebody in this room must have been thinking, what does this have to do with medicine? Did anybody feel like that? What does this have to do with medicine? Nobody wants to admit it? All right, Kristin wondered what it had to do with medicine. So very importantly, all of this technology that we're learning, a vocabulary and a data model and that Atlas tool that we're going to play with, that is not our objective in OHDSI. Our objective is to come up with good clinical questions and generate reliable evidence that we can publish in medical journals so that doctors make better decisions with patients. That is our purpose for being here. The reason I flew across the world to come travel with you is because I believe that you have the ability to come up with really good questions and generate really good answers that need being done. But this can only happen if we actually collaborate together. because most of you don't understand what a common data model is or what a vocabulary is. Most of you think it takes a year to do a study. And if you all work by yourselves, it will take you a year or 2 years or 10 years to do a study. But if I leave you with one thing and one thing only by the end of this week, it's that you shouldn't work by yourselves to do research. You should treat research as an activity where you can work as a team. And your team does not need to be the person sitting next to you. Your team does not need to be the people at your university. Your team does not need to be the people here in Shanghai. Your team could be any researcher anywhere around the world to collaborate to answer a clinical question. I want to be a part of your team, and I want to help you write your papers, but I'm not going to be here in Shanghai for much longer. But that doesn't matter. We can actually collaborate together to generate reliable evidence. We didn't know that. Highlighted that the community is very international. I'm excited about what's happening here in China. One thing I want to highlight about our community, though, it's not just that there's lots of people in different places in the world. It's also that we recognize that you need lots of different skills to do research. Part of the reason why it's hard to write papers is because you need somebody who's a clinical expert. So those of you who are studying to be a clinical expert, raise your hand. How many of you you're in medical school, so you're studying to be a doctor? Raise your hand. Stand up if you're studying to be a doctor. All right, that's better. You guys don't like raising your hands, so I'm going to make you stand up. Okay. So you guys have clinical expertise or are developing it through your school. So once you graduate, you will have clinical expertise. Okay. So you guys can sit down. That's super important. Stand up if you have computer science expertise. You know how to program. Stand up if you know how to program. Stand up if you know how to program.
I saw statistics last night. I'm going to stand there.
Well, you can stand up for multiple things. That's okay. Okay, so notice we have different people standing up with different skills. Okay, many of you stood up because you are going to be clinical experts. We have technical experts as well. How many of you have or are developing skills in epidemiology, in the study of public health? Stand up. Okay. I want you guys to look around. Notice that there's a different collection of people standing up that are epidemiologists. Very good. How many of you people are or are developing skills in statistics? Stand up. Okay, so we've got some different faces standing up, and now some of our epidemiologists also know statistics. Some of our programming statistics. We also have some folks that are just statistics. Very good. How many people have or are developing skills in informatics? We got an informatics, got a couple informatics. Very good. How many people are developing expertise in health policy? Health policy, very good. And we talked about clinical science. So I'll tell you one reason why writing papers is really hard. Because a really good paper needs expertise in all of these things. None of you in this room have all of these things. And I hate to break it to you, but none of you in this room will ever have all of these things. It is impossible to do high-quality research by yourself. Instead, what you need to be thinking about is not how do I learn all the skills to do everything by myself, but instead, how do I learn to collaborate with other people who have different perspectives and different skills so that together we have everything we need to do high-quality research. Okay. Now, none of you stood up by yourself to have this. But do you notice that every one of these categories is represented by at least somebody in this room? What that means is, by yourselves you can't do this, but if we just work together as one group, one class, we got everything we need in this room right now to write a paper, which is why I'm confident by the end of the next 3 days we'll do it. Okay. Importantly, if you're thinking up a good research idea and you know that you have clinical expertise, but what you're missing is programming skills, the OHDSI community is a place where you can come and you can ask your question, your clinical question, to the community and say, I've got a really important clinical question. I just don't know how to run the statistics. And you know what you'll find is that there's going to be people in the community who says, well, I'm really good at doing statistics, but I don't have a good clinical question. I'll help you. And then that person will say, but I don't have the data to answer this question. And someone else will raise their hand and say, well, I have the data, I just can't write the code. And it's so bringing these people together is what OHDSI is all about. And so what I hope will come out of the next couple of days is that you will start to come up with questions, but that you will also join us in this community to participate, so that all of you who expressed an interest in writing medical papers will actually use this community as a way to advance your own research interests. How do you do it? You literally just go to the OHDSI website, OHDSI.org, and you say hi. That's all you have to do to be part of the OHDSI community. It's just say hi. I will be very sad if by the time I get on a plane on Thursday, whenever that is, if I don't see on the OHDSI forums a lot of you saying hi, I will be very sad. Please don't make me sad. All right. There's 2,500 people already on the forums who have said hi. So the more the merrier. Mui talked about the community of data partners. There's over 100 different databases in 20 different countries who have converted the data to the OMOP common data model, what Lingyi presented yesterday. And so this is the world's largest data network, which means there is no longer an excuse to say, I didn't do my research because I couldn't find data. The data's here now, you just need to come to the community. Lingyi presented you the OMOP common data model. Everything we're going to be doing is going to be based on this for the rest of the next 3 days. The important thing to highlight is that when we talk about pieces of data, you'll just want to be thinking about which of these data tables that data came from. So the reason why Mui's presentation yesterday was important, and what Kristin and I will reinforce this afternoon, is that you need to remember these things so that you can ask good questions. If we're interested in cervical cancer, we need to know that cervical cancer is a condition. If we're interested in warfarin, we need to understand that warfarin is a drug. If we're interested in surgical intervention of some sort, we need to know that that is a procedure. And by knowing that, we can then specify questions in a full way. Yes?
I got a question here. Just make an example or think about like a question that is not a good question. So what's like a bad question for you?
Okay, good question. So the question is like, what would be an example of a bad question? So there's two parts of asking a good question, and we're going to go through more examples of this. The first part is just ask a question that is fully specified, meaning you provide enough details so that we understand how to answer the question. And so the most common bad question that I see is when someone doesn't actually provide the full question. For example, a bad question would be, tell me about cervical cancer. That would be a bad question. Why? Because I don't know what to do when you tell me about cervical cancer. If you were to say, I would like to know the age distribution of women at the time that they are diagnosed with cervical cancer, that provides more details. And by providing more details, it makes it clear what you're looking to get. So the first the first thing that I see is the majority of the time questions are underspecified, meaning they don't have enough details. And so we're going to try to help you make sure you know all the details to ask a good question. The second thing that can make I'll say, it doesn't make for a bad question, but it can make for a bad experience, is sometimes the data that are available can't answer the question that you're interested in. For example, if we only have access to the children's hospital data, asking a question about cervical cancer is not going to work. Or if we're interested in studying prostate cancer, and there may be things you need to know about prostate cancer, such as a person's prostate-specific antigen value, which would be a measurement, or you need to know whether a person got a biopsy for their prostate cancer, which is a procedure, or you needed to know that they were diagnosed with prostate cancer, which is a condition. Well, now, if I have a question about people with a PSA value and a prostate biopsy and a prostate cancer diagnosis, it means I need to find a data set that has the condition table and the procedure table and the measurement table. And sometimes people ask questions that require data that the databases don't provide. And so therefore that becomes a disconnect between, it might be a good question, but the data can't support the good question. Does that help? Any other questions? All right. So yesterday you learned about the OMOP Common Data Model, which was basically the way in which we standardize different data into a common format. What Kristin and I are going to focus on for the rest of the next 3 days is how we actually rely on the fact that all data is in the Common Data Model so that we can ask a single research question to all of those different databases, and we can get back standardized evidence. So this means as long as you can come up with a good research question, like what is the age distribution of women with cervical cancer, or what is the gender distribution of atrial fibrillation, as long as you can come up with that question, then we can formulate that question in an analysis, send the analysis to data sets, and the data sets are going to send us back answers. And in fact, that tool that we started to play with yesterday, Atlas, is the tool that makes this entire process possible, so that you will be able to ask a question and get back an answer. So OHDSI is all about collaborating to generate evidence. That's our purpose. What I'm going to finish here with is some examples of papers in medical journals to just get you thinking about good research questions or kinds of examples of research questions. All right, I'm going to skip over this. So to do that, I want you to keep in mind and maybe even draw on a piece of paper or look at this picture on a screen. But this cartoon is going to be really important. This is showing you an example of what one patient's data would look like over time. So on the x-axis, I'm showing you time. I'm showing you the different types of data that we could capture about a given patient, their conditions, their drugs, their procedures, their measurements. Those little icons there I'm showing you represent the data that might be captured in an electronic system. Now, pretty much every research question you're going to come up with is going to be based on the idea that you are going to anchor your question on some event that happens to some patient. And once you know that event that happens to some patient, then we can ask all sorts of questions by looking at what happens before that event in a person's medical history and what happens after that event in a medical history. A very common way that problems get started is you might think about anchoring on a treatment, just as an example. So a treatment, a medical intervention provided by a doctor, is usually performed or administered for some reason. Right? And the reason is usually because a patient has a disease. That's why you're treating the disease. So if you think of the time history, if you find the moment that someone's treated, you should be able to look in the past to see why they're treated. You should be able to observe their disease. But you might be interested in, once you perform a treatment or administer a treatment, you might be interested in what happens to that person afterwards. And you can use any data following that treatment as a possible outcome. So, a single person's record in a medical history can provide a lot of different moments when we could ask lots of different questions. For example, we could anchor ourselves on women at the time that they are diagnosed with cervical cancer, or men at the time that they're treated with warfarin, or people who have a myocardial infarction. Any moment that there's an event that happens to a person represents an opportunity for you to ask a research question. And that research question can be a characterization question. What do these people look like? It can be an estimation question. What are the effects of alternative treatments? And it can be a prediction question. Which patient experiences which outcome? So as long as you can think about this, if you can fill in the blanks of what is the disease you care about, what are the treatments you're interested in studying, and what outcomes you want to study, as long as you can come up with something, then you've already come pretty close to defining a really good clinical question. Because it turns out that an observational database is nothing more than a collection of patients' medical journeys. And what we're going to do is go into those patients' medical journeys and find the people who follow the pattern that you are looking for, and then just summarize what happened to them in the real world. It's not any more complicated than that. We're going to just find the people who have cervical cancer, and we're going to ask, how old are they? It turns out that once we have standardized data to the OMOP Common Data Model, once we've standardized our analysis, that becomes a very, very simple question to ask. But the hard part, and where all of you should be thinking right now, is what is that question that matters? What question do you want to ask that you actually care enough about that you want to turn it into a paper that you're going to publish? So, 3 types of questions. And I'm going to quiz you later to make sure you remember these 3 things. So you might want to write it down. There's clinical characterization. That's the descriptive statistics. It's answering the question, what happened to them? There's population level effect estimation. That's answering the question, what are the causal effects? And there's patient level prediction. This is asking the question, what will happen to me in the future? 3 different types of questions. They require 3 different types of analyses. We're going to teach you 2 of them in depth over the next 3 days. We're going to teach you characterization, and we're going to teach you prediction. If you continue to be interested and excited, you can go take our classes that teach you all about estimation. For the purposes of this week, we're going to hold that on the back burner. Okay. That's probably not a good, that's probably an Americanism. We're going to not teach that for the next week here. So, let me give you some brief examples to demonstrate what's possible in OHDSI. An example of a clinical characterization study was one of our first studies. It was published in the Proceedings of the National Academy of Science, which is a very highly esteemed journal around the world. And it was a paper published called Characterizing Treatment Pathways at Scale Using the OHDSI Network. And in this study, we were able to use databases from around the OHDSI network to study hypertension, depression, in diabetes. And we asked a very simple question. We said, for those diseases, what treatments do patients take? It turns out no one had ever bothered to ask that question before, and so we summarized the answer. And I'll show you the results for depression here as an example. This graph here, what it is showing you is each color represents a different depression treatment that's available in the world. These are different antidepressant drugs. And so the colors reflect the different drugs, and the circles that you see here represent the order in which patients are taking the treatment. So the first circle represents the first treatment choice that patients made. And if you go to a second circle, that means that the patient had to switch from their first drug to a second drug. And if you see it goes on to a third, that means they had to take 3 drugs, so on and so forth. So what you can see on this picture is that for all of the patients around the world that we had access to that had major depressive disorder, we asked what drugs do those patients take, and we found that lots of patients make lots of different choices. 17% of them choose to start on a drug called citalopram. 16% of those patients start on a drug called sertraline. Another 14% start on a drug called bupropion. And you can see that it's a very colorful rainbow. Lots of patients are making lots of different choices. But unfortunately, for the majority of patients, that first drug doesn't work. So they have to try a second drug. And when they go to try the second drug, you can see that again, they're making lots of different choices. And after that, it still doesn't work, so they have to make lots of other choices. It turns out that what we observed is that the guidelines for treating depression don't actually tell us which drug works best for which patients. So instead, what we're doing is we're pretty much giving these drugs at random to patients, and it doesn't work the majority of the time. So then we give them another drug at random, and it doesn't work a majority of the time. And we keep doing that, and patients still keep not getting better. Now, we did this not just in one database, but we did it in Korea, and in the US, and in the UK, and at Columbia University, and in EHR data, and in an academic medical center, and in Japan, and in a poor population, and in an elderly population, and in an academic medical center. We did it in different places around the world to understand, has anybody figured out how to treat depression right? And unfortunately, the answer was no. Everybody seems to show random assignment of drugs. And particularly distressing was that we found that 10% of patients around the world have a sequence of drugs that is completely unique to themselves. So if you are a doctor and you want to learn how to treat your patient, you might think, let's go find all of the patients who've looked like this person in the past, and I'll make my choice based on them. And it turns out for 10% of the people, they have a completely unique treatment sequence, which means we can't learn anything from them. This tells us we need to do better in healthcare, but we also have a big opportunity, which is to use the world to study what's going on and figure out what makes most sense. So this study, how long do you think it took us to do this study? A decade? 2 years? 3 years? 5 years? How long do you think it took? A year? Anybody want to go higher than a year? What's that? 3 months? So the truth of this study was I sat in a bar one day with the other researchers, and we thought of this idea, and we wrote a study protocol to write down the idea once we had it. we wrote down the idea as a protocol. The next week, we wrote the code so that we had something that executed the protocol to generate the results. We sent that to the community. That month, all of these sites had sent back the results. 1 month later, we had a group meeting where we presented the results to each other. It did, in fact, take a full year to get the paper finally published in the Proceedings of the National Academy of Science. So that did take a whole year. But the time from the question to us having the results that are in this paper took us less than 3 months. And in fact, mostly less than 1 month. This is the largest observational study that has ever been conducted in the world. And we did it in less than a month. So here's the interesting thing. We think these results are interesting, but it actually raised more questions than it answered. Because it made us ask questions like, which treatment did patients choose after their diagnosis? That's the question we were answering with this study. But we might be interested in which patients chose which treatments. Or how many patients who experienced the outcome after treatment? So pop quiz, what kind of questions are these? I gave you 3 types of questions you can ask. Characterization, estimation, and prediction. What kind of questions are these questions? Characterization. These are characterization questions because we are simply descriptively summarizing what happened to them. We could also ask the question of, what's the probability that I experience an outcome? Or does this treatment cause an outcome? Or does one treatment cause the outcome more than an alternative? So this question, what's the probability that I experience an outcome? What kind of question is that? Prediction. Because we're now trying to predict in the future for someone else, not just what happened in the past. And this question, does a treatment cause an outcome? What kind of question is that? I can't hear you. Is it characterization? Estimation. This is an estimation question. Does a treatment cause the outcome? Is an estimation question. So it turns out by doing this one study, we were actually able to ask ourselves a lot more questions that we could then do more research on. So we did more research. We actually took those results of depression and we said, lots of different patients are getting lots of different depression drugs, but we don't seem to know which ones work better than others. And so we published this paper in the Proceedings of the Royal Society Philosophical Transactions, which actually does not have the world's biggest impact factor, but is noteworthy because it's the first ever scientific journal. And so now, in addition to having myself in this journal, they have other luminaries like Isaac Newton and Albert Einstein have published here. So I put myself in that same category. So what did we actually do in this paper? Well, we asked the question, can we do estimation questions that allow us to understand which treatments cause which outcomes? I'll just highlight the paper. We were able to actually show that different antidepressant drugs have different effects. And so patients might actually want to choose different drugs depending on what outcomes they care about. We've done other types of population-level effect estimation studies that might make more sense. Here is a very specific one where we asked a question about a specific treatment and whether or not it caused a side effect. The drug was levetiracetam, and there was a question that came from the US FDA of whether or not that drug caused a side effect called angioedema. And so we decided to use the OHDSI network to answer that question. And this is a paper that was published in Epilepsia, which is the top clinical journal for epilepsy, which allowed us to look at that and to determine that we do not see any evidence that this drug has this side effect. This actually was helpful for the FDA to decide how to communicate about the risks of this treatment. Another example is a paper that was published in the JAMA Open, which is a large impact factor journal. And here we asked the question of alternative diabetes treatments. Which of those treatments seem to have an effect on diabetes response as it related to hemoglobin A1C values? And this was a study that was published using the OHDSI network that was able to show differences in second-line treatments. The last category is prediction, and just to highlight some examples of this, we have published a paper that we're going to give you as a reading assignment tonight, actually, for your homework. So yes, you get homework. But this is a paper that we're going to want you to read because the tutorial that we're going to be giving tomorrow and for the rest of the week is going to be based largely on this paper. In this paper, we described how we can use observational data to apply machine learning algorithms to train prediction models to answer the question of what's going to happen to people in the future. And what we've done is we've actually made this such that it becomes a systematic process, which makes it possible for us to do this not in a decade or a year or a month or a week, but to actually be able to do this in a day, to be able to go from a question to an answer by training a model around the world. And so this paper will be useful for you to take a look at as background because we will be talking a lot about it. But as an example of a paper that we've recently published using that approach, here's something very simple. It turns out that in many observational databases, we do not know whether a person is alive or dead. It seems like something you'd probably be able to capture, but many systems do not actually know whether someone's alive or dead. Does anyone have any guesses of why that is? Why would an electronic health record system not know whether a patient is alive or dead?
I think when they are dead, they cannot reach any kind of data. They cannot provide data to those kind of charts.
That's exactly right. So just to repeat it so you can hear it. If you're dead, you have a hard time going back to the doctor's office to provide data in the charts because you're dead. And in fact, a lot of people, they die, and they don't die while getting health care. They die at their home or somewhere else. And so unless somebody finds out that the person died at their home, that information never makes it back into the health system. For those of you who are becoming doctors, you'll probably find that you'll spend most of your time treating the patients that are alive rather than following up on the people who are dead. Chances are you can't help them nearly as much. So, what did we have to do? We had to learn a prediction model to guess which patients are dead. And so we trained a model to use the data to be able to predict, are these people dead? And it turns out that we can actually do a really good job of predicting who's dead. Because it's not very hard. If somebody had a heart attack and has had invasive care in the hospital and then gets hospice and leaves and never produces data again, you know why? Because they're dead. If somebody has cardiac arrest and then magically stops providing data, they're dead. If somebody has serious cancer and lots of treatments and then very invasive hospital care and then magically disappears, they're dead. And so we don't need a data set to have a field that says whether or not someone is definitely dead. we really just need to be able to predict, based on the information we see, whether or not we believe a person is dead. And we were able to show that you can do that task pretty well. It's not very hard. The last thing I'll leave with you before turning it over to Kristin is to highlight an exercise that, in case you are still actually, stand up if you still think I'm crazy. Come on, nobody thinks I'm crazy? All right, one thinks I'm crazy. Yes, Mui and Kristin know me enough to know I'm crazy. So the reason why I'm so confident that we're going to write a paper by the end of this week is because at last year's OHDSI symposium, we had a single 7-hour period of time, more like six period of time, where a group of researchers started the day by asking the people at the symposium, asking them, name an important question that you think matters. And we had 500 people in the room, and they all wrote down lots of different ideas. And then we had the 500 people vote on the single question they thought was most important. And they picked a question, and it turned out it was a question posed by a researcher from China who happened to be over visiting the OHDSI symposium. And she had posed this question, and everyone else in the room thought it was the most important clinical question. So we took her question and we brought it in, and we had a team of researchers sit with her to make sure they understood the clinical question. It turns out that the question was about when a person has an ischemic stroke, there's a chance that there's going to be a complication called a hemorrhagic transformation, which is basically a bleeding in the brain that happens after a stroke as a follow-up care. And her question was, can we figure out which people who have an initial stroke go on to have this hemorrhagic transformation? And based on that clinical question, a group of people got together, including Kristin and Mui. There's Kristin in the up there. There's Kristin right there. And there's our colleague Chung. And so a group of researchers got together to define the problem, which is what we're talking about right now. We had a group of researchers get together to develop a model that could actually predict this outcome. We had clinicians come together and review the results and figure out if they made sense. And then we sent that model to around the world to lots of different data sites. And those data sites took the model and they applied it to their data and they figured out how well that model worked. And at the end of the symposium, Mui and Kristin and other researchers, they got up on the stage and they presented the results of the question that was asked in the morning. So at 9 a.m., a group of 500 people came up with an important clinical question. And at 5 p.m., we showed the results of that question on a stage in front of 500 people. This is work that is now being translated into a medical journal article that the Chinese researcher is leading that activity. But it shows what is possible to go from an idea to an answer in an efficient period of time. Right. So with that, I'm going to turn it over to Kristin, who's going to talk to you specifically about where to begin and to help you start framing clinical questions that you might want to answer. And I don't know how you want to just use my laptop?
Figure if you touch it, then it gets worse,